Thanks for tuning in for another episode of Spoonie Radio. I'm your host, Dr. Courtney Craig. My guest today is Dr. Jared Younger. Dr. Younger received his PhD in experimental psychophysiology in 2003 at the University of Tennessee in Knoxville. He then completed postdoctoral fellowships at Arizona State University and then Stanford University School of Medicine. In 2014, he joined the faculty at the University of Alabama in Birmingham and established the Neuroinflammation, Pain, and Fatigue Laboratory. Dr. Younger's goal is to end chronic pain and fatigue by focusing on inflammation in the brain. He and his group are working to develop techniques for diagnosing and treating neuroinflammation, pain, and fatigue. So welcome to the show, Dr. Younger.
Thank you.
So many people in this community are really excited to learn about your work, and this is all relatively recent, within the past year or two. And long-term patients like myself are really intrigued by some of the research you guys have already uncovered, because it seems like you're looking at chronic fatigue syndrome and fibromyalgia in a different way than we've maybe seen before from other research. So how did you land on this type of research and really hone in on the neuroinflammation specifically when there's so much other research out there looking at different puzzle pieces in MA-CFS?
So I did a postdoctoral fellowship at Arizona State University, and we were looking at rheumatoid arthritis, osteoarthritis, and fibromyalgia. That was the three groups they were investigating, all with chronic pain. And they had a pretty good idea what was happening in RA and had a pretty good idea what was happening in OA, but they had no idea what was happening in fibromyalgia. And being a scientist, I went after what was the most mysterious, the most complex problem. And I also saw these people, there's about 6 million people with fibromyalgia who had really good careers. They were athletes, and then they were completely debilitated when they were hit with this disorder. Same thing with chronic fatigue syndrome. And so it's where I saw the greatest need. And it was also the greatest, I could tell that none of the physicians knew what was going on, and the researchers didn't either. As far as neuroinflammation, everyone was looking at neurons. Everyone was looking at the neuronal system. They were trying to boost serotonin and dopamine, and they were trying antidepressants, and nothing seemed to work. And so what that tells me is that everyone may be on the wrong track. I noticed that a lot of the symptoms, and this was the key thing for me, what got me started in this particular line of research is when I looked at the symptoms, and whether it's chronic fatigue syndrome or fibromyalgia or related disorders, pain sensitivity, profound fatigue, cognitive disruption, sleep disruption, kind of depressed motivation sometimes, all of those, we see that somewhere else. And we see that anytime someone gets hit with a severe illness like the flu and they feel sick for a few days, and we call that cytokine-induced sickness response, and we see it in basically every mammal. And so I said, these symptoms that we're looking at in these patients look exactly like what happens when the immune cells in your brain think you have an infection, and they produce these chemicals to make you feel sick. And so it's really just more of a logic thing than even a science thing. It's like, well, maybe that means in these patients, their immune system has been tricked into thinking there's an infection going on all the time. And so it's producing the symptoms of being infected with something, a virus or a bacteria, when you actually aren't. And it's a dysregulation of the immune system. So that's really how I got started. And it was just saying, where do we see these symptoms? Where does it come up? And is that perhaps a clue as to what's going on in these disorders?
Right. And I think a lot of patients can certainly relate to this idea of having their brain inflamed. But to just kind of take a step back, can you explain more what is neuroinflammation on a physiological level? What's actually happening to cause the inflammation in the central nervous system?
Sure. Yeah, that's a good question. So we have inflammation. We start with inflammation in the body. That's what people are more familiar with. So inflammation is just a response to some kind of injury or some kind of infection, and it's an alarm system that calls all the immune cells to that area, and they mount a kind of a battle against whatever the problem is. So if it's a cut, they'll go to that area to fight out bacteria. You can get inflammation anywhere in your body, and it's a healthy thing if it only lasts a short period of time. So if you get a cut, you want it to be inflamed because that's part of the immune defense against any kind of invading bacteria or any kind of internal problem. But when inflammation goes on for a long time, it causes severe problems. So, for example, people are very familiar with osteoarthritis. If your knee gets inflamed for a week for a problem, that's not a big deal. But if you have inflammation in your knee for years, you're not going to be able to use that knee very effectively. So wherever you have chronic inflammation, you start to have problems in that area. If you have inflammation in your heart, it could lead to heart disease. If you have inflammation in your gums, they're going to bleed. So inflammation over a long time is a bad thing. So just like we can have inflammation in the body, you can have inflammation in your brain. And it's the same basic process, although the cells are a little bit different. So in our body, we have T cells and B cells. We have all these specialized cells. In our brain, we have microglia, and they're responsible for everything. So they're like these incredibly multi-purpose immune cells. But the process is pretty similar. They still, when they think there's a problem, they become activated, which means they change their shape, and they start to throw out a bunch of chemicals to fight that problem. And as opposed to in your body, if you have inflammation in your knee hurts. When you have inflammation in your brain, it affects who you are, because that's what makes us who we are, is what's going on in the brain. So right. You're not going to feel it like pain in your head. It's going to come across as the things we talked about before. You're going to feel really, really tired. You're going to feel like it's hard to get anything done. You may be more sensitive if someone's pressing on your body, because it makes you more sensitive to pain. And it really is going to make you where you just want to be in bed all the time. And so that's so it's different in terms of the symptoms, even though the mechanism is the same. So it's really, your inflammation is just inflammation that just happens to be occurring in the brain.
Mm-hmm. Yeah, good explanation. So a lot of viruses then have been implicated in this illness as potential triggers. And many of them are, like herpes viruses, actually infect nervous tissue. So are these potentially triggers that are setting up a vicious cycle of microglia activation that some patients just cannot overcome?
Absolutely. So there's two scenarios that are possible, and we don't know, and probably both of some people suffer from one, some suffer from the other. In one scenario, the virus gets in your body, and like a lot of herpes viruses, after you fight it off, it stays kind of dormant, or it stays in a suppressed state, and it may hide next to your spinal cord, or it may hide in your brain somewhere. And then when it gets opportunities, it might emerge a little bit, and then your body mounts a defense and suppresses it. So there's a scenario where people could have this chronic viral infection that keeps, maybe every few days, starts to try to get out, and then your body fights it off. And so you're getting these mini infections all the time. That would create the symptoms of fibromyalgia or chronic fatigue syndrome. So that's one scenario, is that you have a chronic infection. The other scenario is that the virus came in, and because it was such a bad infection, think of a really horrible mono illness, which is called the Epstein-Barr virus. And it was such a hit to your immune system that it left the immune system in a sensitized state. And so the virus is gone, but the immune system doesn't realize it, and it continues to operate as if you have an infection. So those would both lead to the exact same symptoms, but we would treat them differently. In the first case, we would want to give antivirals to try to suppress and get rid of that virus. In the second case, we have to find out, why is the immune system sensitized, and how do we get it back to its normal state?
Yeah, that second piece is quite challenging. Do you believe that there is a genetic component here that sets a patient up because of their predisposition to develop this vicious cycle?
Yeah, probably so. We don't know exactly what that would be, but certainly we know enough to know that there's a family history component to this. And if you have a family member who has a classic autoimmune disorder like rheumatoid arthritis, then you're more likely to have something like fibromyalgia or chronic fatigue syndrome. So that tells us there's probably some genetic component. We also know that women are more likely to have these disorders. If you look at children, the rate between boys and girls are very similar, and they're very low until puberty. And then you see the rate in girls start to climb pretty drastically. So there could also be a sex hormone component to it. And it may also be a timing thing. So we're starting to get really interested in, it could be the time in your life when your immune system is assaulted in this way, and it might even be a time in cycles. So there may be times when estradiol or progesterone are high, and then if you get an injury during that time, it's going to be more likely to lead to chronic pain. Now, we don't know that for sure, but there's some preliminary evidence to suggest that's the case. So, yeah, it's probably a combination of the trigger. People who get a horrible infection are more likely to develop these disorders, genetics of that person, and then also the timing of that.
That timing piece is very interesting. I haven't seen anything about that. And that brings up the issue of hormones. And one of the most exciting things that your group has come out with, I think so far, is this small pilot study from last year when you measured inflammatory markers in patients, an extensive look at different cytokines, but there was one particular thing that stuck out, and that was the hormone leptin. So could you talk about that? What is leptin, and how does this fit into the neuroinflammation piece?
Yeah. So we've known about leptin for a really long time, but we didn't realize the extent that it changes our experience. So we used to think of leptin as just an appetite regulatory hormone. So leptin is produced by adipose tissue, which we call white fat tissue. So the kind of normal fatty tissue in our body that we think of, those cells produce leptin. And some other cells do as well, but primarily the fat tissue. So leptin is increased as we get heavier. So with greater obesity, your leptin levels will typically get higher. And then after every time we eat, our leptin levels will increase. And so leptin is one of leptin's main functions is to suppress our appetite. So, it's supposed to be a feedback system where if your leptin levels get really high, you will slow down your eating. And so it regulates how much we eat. If you have no leptin in your body, you may eat all the time, which would be very dangerous and very destructive. So leptin is very important. It plays a very important role in our balance of hunger versus satiety. But it has another function that we discovered more recently, and that is it's inflammatory. So when leptin gets into the brain, it actually sensitizes microglia cells. So those immune system cells I talked about a little while ago, when they're exposed to leptin, they become more sensitive. And so it takes less of a trigger to set them off. And then when they do get set off, they do so much more robustly. So leptin itself doesn't activate the immune system cells, but it sensitizes it. So it's more likely it will be activated by something else. And that's very interesting. So when you get sick, your leptin levels will increase pretty drastically. And that's why people with the flu tend to not eat very much, because their appetite's suppressed by the leptin. Right. So this is very interesting. I mean, we know that it has the potential to sensitize the microglia. And then when we looked in the people with the chronic fatigue syndrome, and we've also seen this in fibromyalgia, we see on days where their leptin is high, those are their worst symptom days. And they track very well with each other. So if you have low leptin, you're probably going to have low fatigue. High leptin, you're going to have high fatigue or pain. So there does seem to be an association there. We don't know exactly what's happening. We don't know if maybe these individuals have developed a resistance to leptin, and so their body's producing too much of it, because these individuals are not necessarily obese. It really, in our study, had nothing to do with obesity. People who were very small actually can still have very high levels of leptin. So something else is going on there.
Yeah, most of the obesity research surrounding leptin is regarding leptin sensitivity,
right?
Not responding properly to leptin signals. So a lot of patients maybe are thinking already, well, how can I reduce my leptin, right? If this is, this is still a small study, are you working on replicating these findings in a larger group?
Yeah, so the good news is those initial results were so strong that the National Institutes of Health, National Institutes of Health gave us a very large grant to study this in about 200 more women. The original study was 10. So we're going to have an excellent opportunity to make sure that this is a true finding. And again, 10 people is very preliminary. The results were very strong because we saw it in so many people, but it's still 10 people. So we're conducting that study right now. I think we've run 2 cohorts already. We started a few months ago, and so we probably have about 20 new people through. and we've got to run a lot more in the next couple of years. So after we do that, we'll have a much better idea of whether this is true or not. So I would tell people probably not to try to manipulate their leptin levels until we get some more information. But there are ways to do it. I mean, they're not fun, though.
Mm-hmm.
The caloric restriction, exercise, but the problem with these things is they have other effects. So, exercise will reduce leptin levels, but exercise also produces other chemicals that may actually exacerbate fibromyalgia or chronic fatigue syndrome.
Right.
So there are drugs that may target leptin, but those aren't available for widespread use yet. So there's not really any great ways yet of truly manipulating leptin levels for a therapeutic effect.
Caloric restriction and periodic fasting is something that I do actually quite frequently to manage my symptoms. But I wonder if you've seen maybe some patients that you've worked with to do this. Does it actually even make any change in the leptin with the caloric restriction as expected, or is it perpetually elevated no matter the food intake?
I think it would be impacted by those things, because when we look at the people, even when we're not trying to change leptin levels, we see their leptin levels are varying drastically within persons. So clearly something is making it go up and down. So I think if they did do fasting or just reduce the caloric intake, it doesn't necessarily have to be fasting,
Mm-hmm.
that probably would impact the leptin levels. So, I always recommend if someone's going to drastically change their diet that it's being supervised by a medical professional. But, it's something that people could try and see. I mean, you would know very quickly if it's going to impact your symptoms or not. But there is it is possible there's a mechanism. If you reduce your caloric intake, your leptin levels will go down. So if leptin was driving your symptoms, that could help.
Okay. Now, getting back to the microglia piece, you mentioned that we don't really have many options as far as maybe leptin modulation yet, and we don't have enough information yet to think about that. But microglia inhibition is that more well known? Are there more treatment options available there that could potentially be helpful?
Yeah, this whole line of research is pretty new. So we're talking about going back maybe 6 years. And that's not very long in science because things move pretty slowly. So the line of research is still in its infancy. And so there aren't a lot of agents for human use that target the microglia. Now, there are many labs that are producing agents, but they're being used in animals right now. That's the classic process is they go through a lot of animal research before we try them in humans. And our lab doesn't do animal stuff, but we certainly follow that science. So there's a lot of things that are coming along that are being designed specifically for that purpose. I can't really guess how long it'll take before they start being used in humans. Probably 3 to 5 years before we start seeing those clinical trials. In the meantime, there are chemicals that were used for other purposes, and then they were subsequently discovered to also reduce microglia sensitivity. And so low-dose naltrexone is the one our lab works with the most. Mm-hmm. So we can talk about that one. Dextromethorphan, which is something you can find in cough syrup at low dosages, that also suppresses microglia. There's a drug called Abudilast. There's one called AV411. So there's probably, and minocycline. So there's probably 5 that are being used currently in science that people can actually try right now. And those all reduce microglia excitability. And then there's probably another 5 to 10 agents that we probably could use in people right now, but we haven't seen any trials that have done that. So there are a few things we can try. And certainly one of the goals of our lab is we want to do some really quick clinical trials, maybe 10, 20 people, try all these agents and see which one looks promising. And then we'll get additional funding to do a larger, more proper clinical trial.
Right. I don't know if any CFS physicians out there are that open to trying some of these experimental medications, but the information is there.
Yeah, and we have, we now have multiple publications about especially low-dose naltrexone. So certainly any physician has access to that information. They can read what's the chances of success. They can see what the side effects are, which are pretty minimal in our experience. And any physician can prescribe these things. It's just, they're looking out for their patients and they want to be safe. And so they like to see huge clinical trials with hundreds or thousands of people. So they're confident that they're giving something that has been very thoroughly screened and vetted. And so I understand that small pilot trials don't necessarily change physicians' prescribing habits. There's a company, I think, that's going to produce a commercial version of naltrexone at the very low dose. Mm-hmm. I can't remember what it's going to be called, but I do think that's coming along. And once there's a FDA-approved product for this, more physicians will be prescribing it. So I think you'll see more. I hear from rheumatologists all the time that are trying this, and I think we'll be hearing more about it in the next few years.
Great. A lot of listeners of the show are also very interested in supplements and natural products. So are there any strong lines with different types of natural products affecting neuroinflammation?
Yeah, there's some really good clues, almost all from animal literature. So we'd have to guess what the impact on humans would be. But my angle is inflammation. And so we're going to be targeting specifically agents that have the ability to cross into the brain and reduce, again, microglia excitability. And there's actually quite a few old Chinese medicines. There's herbal Indian medications that can do that. So I can give you a few of those. And we're actually going to be testing 9 of these in the next few months. We're starting with Gulf War illness, which is very much like fibromyalgia and chronic fatigue syndrome, but then we're going to expand it to other diseases as well. But at the top of the list in terms of looking over the literature, and my best guess is curcumin. And so not cumin, people get that mixed up a lot, but curcumin is from turmeric root. And turmeric root is a very powerful anti-inflammatory agent, and curcumin is the active ingredient in turmeric root. And so you can buy curcumin by itself at really high potency. Now, it has to be combined with black pepper in order for your body to absorb it. And it doesn't stay in your body very long. I think that's why it hasn't been a blockbuster agent, because we need to find a way to keep it in your system so you don't have to take it every few hours. But curcumin is a good one. Really, in terms of things you intake, I think the key is really the anti-inflammatory stuff. So I think it's worth people trying. That would be a Mediterranean diet. So a lot of omega-3 oils, reducing a lot of the omega-6 oils, getting a lot of colorful vegetables, putting sugar at really, really low levels, like hopefully even below 15 grams a day. So super low sugar is very, very inflammatory. Decreasing the carbs, which can act like sugar if they're simple carbs. And then getting a lot of the spices like ginger, cinnamon, peppers that have anti-inflammatory properties are probably the best bets.
Yeah, all good tips, good tips. So your current projects now, you're in the Alabama area, and if any listeners are from that area, is there ways that they can get involved in some of your projects, maybe act as subjects or help with controls? How can listeners get involved with some of these projects?
Yeah, absolutely. I mean, that's the most important part of the research. Everything we do has human participants, and so the most important part of these studies is actually getting people who are willing to give their time and participate in the studies. And so we're always very grateful for people who are willing to be in our studies. And you're right, it is patients with these disorders, and we need healthy individuals to act as controls in all of our studies so we can really find out what's the normal system look like, so we can know what the dysregulated system looks like. So the best way, we have a Facebook page for the lab. I think if you're on Facebook and you just typed neuroinflammation, pain, and fatigue in the search box, you would get us. And that has a link to our online screener. So we typically have people do an online screening thing first, and then we can call them and do further screening to see if they're eligible for our studies. They can also sign up for our newsletter, and I guess it's okay to put out an email address. It's a generic one, so youngerlab@uab.edu, and they can sign up to our webpage there, or our newsletter. And we also have a webpage if they do younger, neuroinflammation, pain, and fatigue. It'll come up and they can sign up for a newsletter there. And that'll give them the links where they can do the screening and get involved in the research.
Great. And all those links will also be available in the show notes when this episode is transcribed on the blog. Are there any other projects that you can talk about that maybe we've missed so far?
Yeah, we do a lot of things. So very busy lab. And the thing is we're not, we don't use a particular technique. We will use whatever it takes to get at this. Remember that we've got this hypothesis that there's inflammation in the brain. The problem is you can't get to the brain in living humans. I mean, you've got the skull. You can't put in needles and draw stuff out. So it's very complex to go down this line of research. So we have to be very creative and we have to use a lot of different techniques. So we talked about the immune stuff. We talked about some drug studies we do. We also do a lot of neuroimaging because that's probably the best way of seeing what's going on in the brain without actually taking someone's skull off and getting to their brain. And so we're working on some new, I think, interesting techniques to try to detect. Right now, we have no way of knowing when someone has neuroinflammation. There's no test for it anywhere in the medical world. So we're trying to develop that. One thing we're working on is called magnetic resonance spectroscopy thermometry. And what that is, it's just if everyone's had an MRI scan, it's like that. It's the same scanner, but we change the code a little bit so it actually gives us brain temperature. So just like if you want to know if you have an infection, you put a thermometer somewhere. Now we have a way of doing that in the brain. And so we think if someone has inflammation that's locked in the brain, their brain temperature is going to be higher than the rest of their body. And so we're going to see if that discrepancy between brain and body may be a objective test for brain inflammation. And if that's the case, that would be very, very helpful because you could do that really quick scan. I mean, it's 20 minutes. Say, okay, this person has neuroinflammation. We need to give them anti-inflammatories that can target the brain.
Fascinating. Is that an invasive type of technique? 20 minutes, just wearing it like a skull cap? How does that work?
No, it's not invasive at all. It basically uses big magnets, so you don't feel a thing. There's nothing injected. You have to go to a special room. You have to take off all your metal, and it pulls you into the scanner. So your kind of head's kind of going into a tube for about 20 minutes. But that's about it. You just lay there quietly for 20 minutes and hear some funny noises as it takes the pictures, and then you get out. So it's pretty simple, pretty low impact for the patients.
Very cool. I would love to know the temperature of my brain, especially on days when I'm having a relapse. It certainly feels on fire.
That's going to be one of our first studies, is to take individuals who have fluctuations and then scan them on good days and bad days. And that would be excellent support for the hypothesis if we see that the brain temperature is elevated on the bad days. I mean, that would be a groundbreaking paper. And it may be more important than just for pain and fatigue. I mean, that may have implications for depression. We think a lot of cases of depression are also caused by brain inflammation. A lot of neurodegenerative disorders, I'm thinking of Alzheimer's and Parkinson's, and even just normal aging. So as people get older, they become more easily fatigued. They become more sensitive to pain. Their motivation decreases. And it's possible that those things are being caused by low-level inflammation in the brain. So we may be able to prevent some of all the bad stuff that we think is inevitable with aging. It may not be inevitable at all. We may be able to treat it.
That's really exciting. It's tying all those pieces together. And that's one thing that is very interesting about your research that I think is unique, is you measure patients on their good days and their bad days, and you take these blood measurements every single day consecutively, which we don't really see in a lot of other papers. I mean, this makes for very strong research.
No one else does it. There's a good reason they don't. I mean, you can imagine it's just the practical issues of trying to have someone come in every single day, same time of day each day, to do a blood draw. It's asking a lot. Now, we compensate people pretty well because we realize it's disrupting their life quite a bit. But it's really not that bad. You would think, it'd be really tough to be stuck 25 days in a row. But when you use these really, really tiny needles, we're talking about 23 gauge needles, and you have really skilled nurses, you can get through, and I think I've showed pictures of this before in some presentations, you can get through the whole 25 days without any bruising if everything goes right. In fact, most people don't bruise over that whole period. And so it's actually not bad. They're very small needles. And you're right that the information it gives us it's tremendous. It is far beyond what you get by just drawing one sample from hundreds of people. This is a totally new dimension to the information, and it's revealing things that you cannot get any other way. So we're really excited about this approach. And what we're working on now is ways to make it easier. So there's actually some startup companies that are developing ways to do this at home through little kits. I'm not going to mention any companies by name. I can't remember the names, but there's multiple companies that are looking at ways you can just do a little finger prick that you can barely feel, and it'll actually run the test for you at home and then log it to your smartphone. And so we're definitely going to be talking with those companies and trying to find ways where people just do this themselves, and that way they don't have to come into the lab. But in the meantime, we're still getting great data from this, and I'm glad that the NIH liked the idea, and the Department of Defense did as well. So we're getting a lot of funding to pursue that type of research, and I think it's going to give us some really good results.
Yeah, I think it will. This is fantastic news, fantastic information. We're about out of time, but I want to thank you so much for really looking at this illness kind of outside the box. And I'm looking forward to all these projects coming out. I wish you the best of luck in that.
Thank you. I'm happy to be doing it. It's really fun, and I hope we come up with the cure sometime soon. That's definitely what we're working on.
That's great. Thanks so much. And thanks again for tuning in for another episode of Spoonie Radio. If you like the show, head on over to iTunes, give it a review, give it a rating, and don't forget to subscribe so you never miss an episode. This is Spoonie Radio, signing off.